compared the efficacy of these. No studies have compared the efficacy of the second-line options directly. Gabapentin has been evaluated for trigeminal neuralgia in a meta-analysis that included 14 small clinical trials where it was compared with carbamazepine, which reported similar efficacy between these two drugs, with gabapentin showing lower rate of side effects. Baclofen, on the other hand, has been assessed in a single clinical trial and it demonstrated efficacy against placebo. It showed a higher response rate when used in combination with carbamazepine. Lacosamide is emerging as a potential treatment option for patients with carbamazepine refractory trigeminal neuralgia. In view of the emerging evidence supporting lacosamide, it is hypothesized that lacosamide could be a viable alternative to traditionally assumed second-line treatments such as gabapentin and baclofen. To explore this hypothesis, an exploratory retrospective study was designed, which aimed at comparing the real-life effectiveness and tolerability of lacosamide, gabapentin, and baclofen when used as second-line treatments for trigeminal neuralgia. So methods, study design, and the settings. This is a retrospective cohort study where they examined consecutive patients treated in a neurology clinic of a tertiary reference hospital between January 2015 and December 2023, who were diagnosed with trigeminal neuralgia. The records were analyzed by 3 neurologists specialized in headache and facial pain. Participants and interventions. Participants were included if they met the diagnostic criteria for trigeminal neuralgia as outlined in the 3rd edition of the ICHD, who had either not responded to carbamazepine or experienced an incomplete response or could not tolerate it, that is inefficacy or intolerability, and were subsequently prescribed lacosamide, gabapentin, and baclofen as second-line treatments for trigeminal neuralgia-related pain. Exclusion criteria included prior use of any trigeminal neuralgia medications other than carbamazepine, prior trigeminal neuralgia surgery, prescriptions for regions other than trigeminal neuralgia, or incomplete data, specifically missing follow-up information for at least 3 months after discharge. So treatment doses were individualized by the attending neurologist based on the clinical judgment and patient comorbidities. Regular blood tests and electrocardiograms were performed throughout the follow-up period. Follow-up visits occurred every 1 to 6 months, depending on patient needs. So variables. Data collected for each patient include age, sex, etiology, MRI imaging findings, time since diagnosis, pain distribution, and characteristics. Carbamazepine dose, which was used, reasons for carbamazepine discontinuation, initial and maintenance doses of second-line treatments, patient reported clinical responses at each visit, adverse effects, treatment adherence, hospital admissions, and eventual surgical interventions. So outcome measures. There are 2 kinds of outcome measures here. The primary endpoints for the proportion of patients achieving pain relief, defined as patient-reported improvement, documented in clinical records, and sustained treatment without the need of additional therapies or emergency admissions for at least 3 months, excluding treatment discontinuation due to clinical improvement. The incidence of adverse effects is also a primary endpoint. Secondary endpoints included proportion of the patients achieving pain-free status, defined as complete absence of pain at any point during the first 3 months of treatment. Treatment retention rate, reasons for discontinuation, and necessity for subsequent surgical intervention within 3 months. These are included in secondary endpoints. So results. So by using this criteria, total 537 patients were identified, out of which trigeminal neuralgia code in the diagnosis were identified. From these 537 patients, 488 patients were excluded. Reason goes like this. 205 of these 537 did not meet the ICHD 3 criteria for trigeminal neuralgia. 133 had incomplete records. 44 received only carbamazepine, and 106 did not receive lacosamide, gabapentin, or baclofen as second-line treatment after carbamazepine failure. So after excluding 488 patients, we were left with 49 patients. So out of these 49 patients, 22 patients were prescribed lacosamide, 13 were prescribed gabapentin, and 14 were prescribed baclofen. So descriptive data. The mean age of the patients was 62.1 and 53% were female. The median duration of since trigeminal neuralgia diagnosis was 3.4 years. Among the cohort, 20 of the 49 patients had MRI image, and 8 of them had confirming actual neurovascular comparison. Classical trigeminal neuralgia picture was seen in MRI. Carbamazepine failure was due to inefficacy in 37 of the 49 patients and intolerance in 12. The median maximum daily doses was 1000 milligrams for 1000 milligrams with a median duration of 37.8 months of carbamazepine. All patients were followed for at least 3 months with a median follow-up duration of 6.4 years. Eventually, 19 of the 49 patients required subsequent trigeminal neuralgia surgery at a median time of 20.6 months. So these are the treatment groups. So it is divided into 3 groups, each one having lacosamide. 22 people were prescribed lacosamide, 13 were prescribed gabapentin, and 14 were prescribed baclofen. Age, as we don't see a statistically significant difference in the age, but mean age is 58.5 for lacosamide group, 67.3 for gabapentin group, 62.7 for baclofen group. 50% of the patients were females in lacosamide, 62% were in gabapentin group, 50% in baclofen group. Secondary etiologies, as in lacosamide group, there was 1 meningioma and 1 multiple sclerosis. In gabapentin group, there were 2 multiple sclerosis, and in baclofen group, there are few multiple sclerosis and 1 acoustic neuroma. Presence of concomitant continuous pain was seen in 36% of the lacosamide group, 31% in gabapentin group, and 21% of the baclofen group. So, reason for carbamazepine failure. Because of the reason, the second drug was prescribed. Inefficacy was seen in 73% of the people in lacosamide group. 54% were prescribed gabapentin because of inefficacy of carbamazepine, and in baclofen, 100%. Intolerance, because of intolerance to carbamazepine, 27% of the people were prescribed lacosamide, and 46% of the people in this group were prescribed gabapentin. 0% was 0% in baclofen group. The reason is all the patients who continued in baclofen group had concomitant carbamazepine. There is a statistically significant difference in the carbamazepine failure groups. Concomitant carbamazepine, it was seen at 68% of lacosamide group, 54% in gabapentin, and 100% in lacosamide group. Baclofen group, sorry. Time since trigeminal.
Just very briefly, so we can assume from those numbers that when people when carbamazepine wasn't working well enough, they left people on carbamazepine and added in one of these other agents as a secondary agent alongside carbamazepine. But obviously, if they were intolerant of it, they brought them off carbamazepine, and these were used presumably as monotherapy. Yeah?
Yes, sir.
Okay. All right.
In efficacy, what they're saying is, initially the response was excellent. Later on, what they were saying is pain relief is not that great. So the reason they had to add a second drug for that. And in intolerance group, because of adverse effect, they had to totally take them off the carbamazepine and add the second.
Okay. Okay.
Sir.
That's great. Carry on.
Sir. So median treatment maintenance group was 200 milligrams in lacosamide, 900 milligrams in gabapentin, and 40 milligrams in baclofen. So secondary etiologies include 1 case of multiple sclerosis and 1 meningioma in lacosamide group, 1 multiple sclerosis and 1 meningioma in gabapentin group, and 1 multiple sclerosis and 2 pontocerebellar angle tumors in baclofen group. Statistically significant differences were seen in concurrent use of carbamazepine during second-line treatment, which was observed in 68% of the patients receiving lacosamide, 54% receiving gabapentin, and 100% of those receiving baclofen. Notably, carbamazepine was maintained for all the patients who failed due to efficacy, as significant pain improvement was initially achieved in many cases. The median initial dose of lacosamide 200, for gabapentin it was 600 milligrams with a maintenance dose of 900 milligrams. Median initial daily dose of baclofen was 30 milligrams. and the median range maintenance dose was 40 milligrams in baclofen. Outcome data. Pain relief was achieved in 15 of the 22 patients who started on lacosamide. 7 of the 13 patients, that 54%, started on gabapentin. 9 of the 14%, that is 64% of the patients, started on baclofen. Adverse effects were reported in 46% of the patients started on lacosamide. 31% of the patients started on gabapentin. 36% of the patients started on baclofen. So proportionate type of adverse effects for each treatment groups. In total, that is, as said earlier, 46% in lacosamide, 31% in gabapentin, and 36% in baclofen group. Commonly seen were dizziness, somnolence, nausea, and pruritus, cutaneous rash, hair loss. First grade AV block was seen in lacosamide group. These are the common adverse effects noticed in this in all the 3 groups. Most common being dizziness, followed by somnolence and nausea. So pain relief. This is the graph showing proportion of the pain relief adverse effect and proportion of treatment discontinuation due to adverse effects for each treatment group. So 68, 54, and 64 are the percentages are the number of patients who achieved pain relief while being on lacosamide, gabapentin, and baclofen group. 46 and 31, 36. These are the percentages of adverse effects seen in lacosamide, gabapentin, and baclofen group. Discontinuation due to adverse effects more was seen. It was seen in 23% in lacosamide, 31% in gabapentin, and 21% in baclofen group. So secondary endpoints. Complete absence of pain was within the first 3 months of treatment was observed in 8 patients receiving lacosamide, 7 patients receiving gabapentin, 3 patients receiving baclofen, 36, 54, and 21. During the follow-up period, which has a median duration of 6.4 years, 30 of the 49 patients discontinued their treatment with no statistically significant differences in the reasons for discontinuation. Time to treatment discontinuation was 4.3 years median, that is median time for lacosamide, 5.4 years for gabapentin, and 1.9 years for baclofen. And subsequent trigeminal neuralgia surgery was required within the first 3 months of treatment initiation in only 1 patient, that is who was in baclofen. So reasons for treatment discontinuation due to follow-up. 50, 69%, 11, 9, and 10, that is 50% in lacosamide group, 69% in gabapentin group, 10 in baclofen group. Treatment failure, which is because of 2 reasons. One is due to intolerance, was seen in 23% of the people who were assigned to lacosamide, 31% of the people who were assigned to gabapentin group, and 21% of the people who were assigned to baclofen group. And the treatment failure inefficacy was seen in only 9% of the people assigned to lacosamide group, 23% in the gabapentin group, 21% in baclofen group. Clinical improvement. Treatment discontinuation due to clinical improvement was seen in 4 of the people assigned to lacosamide group, 2 of the people assigned to gabapentin group, and 4 of the people assigned to baclofen group. That is 18%, 15%, and 29%. So this is the flowchart which is showing pain relief and adverse effects in overall. So in 75% of the people, carbamazepine was changed due to inefficacy. Out of this, they are divided into 3 groups, out of whom 11 out of the 16 achieved pain relief in lacosamide group, 4 out of the 7 achieved pain relief in gabapentin group, 9 out of the 14 patients achieved pain relief in the inefficacy group. Adverse effects were seen in 9 out of 16, 1 out of 7, and 5 out of 14, the other 3 groups. And carbamazepine was changed due to intolerance in 24.5% of the patients. So in these people, pain relief was achieved in 4 out of 6 people in lacosamide, 3 out of the 6 people in gabapentin group. And adverse effects are seen in 1 out of 6 in lacosamide group, 3 out of the 6 people in gabapentin group. In the intolerance group, there is no baclofen because baclofen was always used in concomitantly with carbamazepine in this study. Discussion. This study is one of the first to directly compare second-line treatment strategies following carbamazepine failure. Considering that carbamazepine's initial effectiveness as a first-line treatment in real life has been reported at 88%, with a 44% incidence of adverse effects and a 30% rate of treatment discontinuation due to side effects. The results observed in this study are promising. This is especially noteworthy since the patients included in the study had already tried carbamazepine, indicating a more refractory form of trigeminal neuralgia. Lacosamide has been scarcely studied in trigeminal neuralgia. There was only one retrospective study that has analyzed its effect on patients with refractory trigeminal neuralgia who had already tried carbamazepine or carbamazepine. In that series, lacosamide demonstrated a pain relief rate of 66%, with mild adverse effects occurring in 33% of the patients. Gabapentin, a meta-analysis that revealed 16 small clinical trials comparing gabapentin to carbamazepine, found no evidence of superiority, but it demonstrated a similar efficacy, with gabapentin showing a lower incidence of adverse effects, as in 26% compared to 48% with carbamazepine. An observation also comparable with this study's finding. And for baclofen, the only published trial reported a 70% effectiveness rate and a 12% incidence of adverse effects in an extended open label phase, which included 50 patients. The discrepancy in adverse effects could be attributed to the fact that all the patients treated with baclofen were also treated with carbamazepine, whereas in the above clinical trial, only 23 of the 50 patients were on carbamazepine, and it was gradually withdrawn if pain improved after baclofen introduction. Additionally, the trial only reported major adverse effects, those leading to baclofen discontinuation, likely underreporting minor adverse effects, which were seen majorly in this group, in this study. The concomitant use of carbamazepine is another important factor to consider. While the rates of carbamazepine concomitants were similar between lacosamide and gabapentin groups, that is around 68% versus 51% respectively, all the patients in baclofen group were also treated with carbamazepine. This practice is justified by the findings in the baclofen open label trial, which demonstrated that patients responded twice as often to the combination of baclofen with previously ineffective carbamazepine compared to baclofen alone. As a result, baclofen is almost always used in combination with sodium channel blocker. In the case of baclofen, the strategy involves adding baclofen to the ongoing carbamazepine treatment when ineffective, whereas for lacosamide group, the strategies involve either adding or switching to these medications. Adverse effects with the study drugs were not uncommon. That is, 46% of them were seen in lacosamide, 31% of the patients on gabapentin had some adverse effects, and 36% on baclofen. Most adverse effects seen in this study are mild and led to treatment discontinuation only in only 23% of the patients on lacosamide, 31% of the patients on gabapentin, and 21% of the patients on baclofen. Furthermore, patients receiving combined sodium channel blocker treatment, that is carbamazepine plus lacosamide, face an increased risk of adverse effects, but not in combination with gabapentin and baclofen. This trend was observed in the study, where a slightly higher rate of adverse effects were noted among those treated concomitantly with carbamazepine and lacosamide. That is, 9 out of 16 patients are concomitant carbamazepine and lacosamide group. In this study, a significant proportion of the patients reached a pain-free status within the first 3 months of treatment. Although not statistically significant, gabapentin has the highest rate of pain remission, with 7 out of the 13 patients. That is 50%, 53% of the patients achieving this outcome, followed by lacosamide with 8 out of the 22 patients, that is 36%, and baclofen with 3 out of the 14 patients, 21%. Highest number is seen with the gabapentin patient. The reasons for treatment discontinuation are similar across all the 3 groups. However, a trend towards a greater discontinuation rate due to intolerance for gabapentin exists. 31% of the patients compared to 23% of the patients with lacosamide and 21% of the patients with baclofen. In contrast, lacosamide was rarely discontinued due to inefficacy, with only 9% of the patients stopping treatment for this reason, compared to 23% of the patients for gabapentin and 29% of the patients for baclofen. Only one trigeminal neuralgia surgery was performed within the first 3 months of starting treatment. However, surgeries eventually became necessary for a substantial portion of the patients, 39%, reflecting the persistent and refractory nature of trigeminal neuralgia in individuals requiring second-line pharmacological treatment. So, to conclude, in this small retrospective study, lacosamide showed comparable effectiveness and tolerability to gabapentin and baclofen in patients who had not responded to carbamazepine, thus supporting a potential viable second-line treatment option for patients with refractory trigeminal neuralgia. So, further prospective studies were needed to validate these findings. Sir,
very good. Well, well done, Dr. Vikram. That was
thank you, sir.
very, very, very nicely summarized.
Thanks.
So, does anybody want to ask anything or comment on anything? First off, does anybody have anything that they want to ask or comment on initially before we kind of delve into just a few bits and pieces on here? Okay. So look, first question, whenever you're reviewing a paper, one of the first questions to ask is who wrote this paper? Where do they work? What type of work are they doing?
This is a tertiary, yes, sir. This is a tertiary center, sir. This paper is done in Barcelona, Spain, sir.
Okay, so it's a Spanish,
yes, sir, Spanish
center,
yes, sir.
And it's a tertiary referral center.
Yes, sir. It's a university hospital, sir.
Yeah. Okay, so that's important, isn't it? Because obviously,
yes,
for example, lacosamide, to my recollection, was only available in the UK from about 2016 or 2017.
Oh.
So it was a relatively recently introduced medication, and so obviously that's quite important, and obviously, again, also, the nature of a tertiary center will mean that you are getting probably an unusually complex and difficult set of patients in. Now, for a study like this, that doesn't really matter because there is no doubt, there's consensus about what the first line treatment is for medical treatment is trigeminal neuralgia, which is and has been since the 1960s carbamazepine. Do you think there is? I mean, I don't know. And again, this is a good question anybody else can answer. I mean, what medication would you typically use as a second line for trigeminal neuralgia if carbamazepine wasn't working, or if people hadn't tolerated it?
We usually start gabapentin, sir, here.
Okay. Does anybody else use anything else differently?
Yes, as a second line? From Latin America, we use gabapentin as the second lection, but 2 years ago we tried lacosamide, but not with carbamazepine.
Yeah.
I mean, instead of carbamazepine, we try lacosamide. I believe 2 sodium blockers are some risky things to do. 2 sodium channel blockers.
Risky in what way, do you think?
If cardiovascular being blocking, EVD blocking.
Do they work? I mean, what's the Dr. Vikram? Do you know? I mean, what's the difference? What's the difference between the mode of action of lacosamide and carbamazepine in simple terms?
This is a very difficult to say, but the original are sodium channel blockers. And in some instance, we use an infusion. In the emergency ward, we use an infusion.
But do they block the same sodium channels?
Probably not.
No, they don't. I mean, the simple answer to that question is they don't. They block, the lacosamide blocks slow-acting sodium channels. Whereas carbamazepine and lamotrigine, and the other kind of phenytoin and the other sodium channel blocking anticonvulsants generally block fast-acting sodium channels. So they do actually, the action is on a slightly different, I mean, they are sodium channels blockers, but it's a slightly different set of sodium channels. So there is I mean, you're right. I think that there is a slight sort of, sense that giving two drugs that work on the same overall pathways, even if they're slightly different targets, is perhaps potentially an issue, but they do work in slightly different ways. I mean, obviously, the other drug, I guess that, I mean, if you go back to the 1960s,
we give, sir, amitriptyline, sir.
Yeah, is there much evidence behind amitriptyline as a treatment for trigeminal neuralgia? I mean, the answer is not much. There's some very old studies, but not much. If you go back to the 60s and 70s, people would have quite frequently used phenytoin. And I guess people would quite frequently use lamotrigine, particularly if people didn't, particularly people didn't tolerate carbamazepine, because again of the similarities. And then, there's quite a number of studies. And it's quite interesting that they didn't necessarily choose lamotrigine as an option here. And I don't know whether that's because they didn't use it or whether because they felt actually it's such an established second-line treatment that there was no novelty to it. So that's the first question. Now, the second question, and I don't think this is addressed in the paper, but you can tell me if I'm wrong. How did they choose which of these drugs they were going to give to which patient? How did they, do we know anything about why they chose to give some patients lamotrigine, some patients baclofen, some patients gabapentin?
No, sir, nothing much was discussed in the paper, sir.
Yeah. So what is the potential? What sort of issues might that raise? What sort of potential problems
Bias.
might that?
There can be a bias in the selection, sir, because depending on the person who is assigning, he might have a preferential drug with which he is comfortable with, as there are no clear guidelines which are used to add on which drug to which patient in this case.
And what about issues around patient selection, do you think?
If there is intolerance to the drug, they didn't add the baclofen was not used, sir. Here if there is intolerance, they shifted to gabapentin and lacosamide, sir. Baclofen was only used in the concomitant thing with the carbamazepine here, sir.
I mean, this is obviously a retrospective observational study. We don't get much detail. And of course, I mean, I guess the danger in this scenario is that, I mean, firstly, the numbers are quite small, aren't they? I mean, if they've got 537 patients and they've only got 49 that they put 49. On, which is about 10%. So it's a fairly small proportion that they're putting on these drugs. But because there's no details about how they chose what to do, it is at least potentially possible that some of the decision may relate to, for example, the perceived severity of the condition, and so there might be a degree of bias in terms of patient selection.
Yes, sir.
I mean, we don't know, and we can't know, and in a sense, this type of study, that's always going to be a limitation of a retrospective, sort of case review type study, because when you're looking at this, and but it does mean that you can only draw you can only draw the very, very barest comparative conclusions from this type of study. So that's really important. Again, coming back to the nature of what the nature of the study. As a retrospective, cohort study of this type, there's going to be a lot of potential biases, and that's going to be very difficult for them to, you can't really get rid of that. You have to basically take that into account when you're reading it, and they also have to take that account, or should be taking that account when they're presenting their findings. I guess there were some interesting things in there. I think one of the most interesting things for me is that their response rate. So they put 13 people on gabapentin. And their primary outcome, which is pain relief, was they got 7 out of 13 got pain relief. But then they also had 7 out of 13 who were pain-free. So that's quite interesting, isn't it? That everybody that they put on gabapentin that responded to gabapentin seems to have been
Yes, sir.
rendered pain-free by gabapentin,
Yes, sir.
which is a slightly surprising outcome. Well, it certainly surprises me. But you know, it's an interesting one, isn't it? And you again, because you sort of expect there to be a variance in response, that some people would
Yes,
get
sir.
pain-free, some people would get a pain response, and some people it wouldn't respond to. So that's quite interesting. And again, they don't really address that. And again, the numbers are so small, they can't be very difficult to comment on that. But it's an interesting thing, which is because that was not the truth for lacosamide or baclofen.
No, sir.
That, you know, there were, you know, 50% of people that didn't respond and about 30% of people that got some relief, and then a small 10
Yes,
to
sir.
15% that seemed to become pain-free on them. And I think the other sort of thing that was quite striking to me, well, again, they didn't really seem to provide much data on, is which of these patients ultimately went on to have surgical surgery. And they didn't really, you know, again, because there was one patient early on
Yes, sir.
in the baclofen group in the first 3 months.
Yes, sir.
But they said 19 out of them went on to have surgery.
In the long term, they didn't mention which group of the people went to.
So they didn't mention which group, and they didn't
No,
mention, you know, I mean, again, it would be quite interesting to know, even just on a kind of basic level, whether those were the patients that had, for example, neurovascular contact, were they more refractory?
Yes.
Or, you know, were the MS patients more refractory? But then, you know, and then what surgery are we talking about? Are we talking about, you know, ganglion injections, or are we talking full-blown microvascular decompression?
Decompression.
So again, you know, the numbers are very small, but it would have been interesting, I think, wouldn't it, to have understood whether there was any kind of real difference in what those patients were.
So,
would this paper change your practice?
No, sir.
Would you have considered lacosamide as an option for trigeminal neuralgia already before you read this paper?
I knew it was being used, but I never used, sir. I used gabapentin or baclofen earlier.
Yeah.
Probably I might try now, sir.
Has anybody else on the call, apart from me, used lacosamide to treat trigeminal neuralgia? I think
yes, I did.
Yeah.
I used lacosamide.
And did it work, Lucas?
Yes.
I think my impression, and it is, and I must say that it's from a very low number of patients, lower than presented in this trial, is that it can be quite a useful drug in this area. And I think lacosamide, in my experience using it for this and also for epilepsy, is that it's generally a pretty well tolerated drug. Do you not find that?
Yes, and
Dr.
I will
Vikram
change
shaking
it.
his head.
Yes, without so many problems. I think that there is so many adverse events. I didn't find so many adverse events.
For epilepsy, we were using it from a long time. So for trigeminal neuralgia, till now I never used lacosamide as a second line drug. For epilepsy, we were using lacosamide from a long time.
I think it would be, you know, it's an area where, I mean, again, you know, you know, there's a lot of, you know, it's a difficult you know, it can be a very difficult thing to treat, and obviously, you know, there are some you know, clinical trials that are ongoing, but again, the numbers are still very small for lacosamide. You know, there's a lot of interest in, I think the people that make botulinum toxin are very interested in trying to develop forms of the toxin that do not cause motor weakness to be potentially used for trigeminal neuralgia and other conditions. And again, you know, it's an area of open interest and research. Okay, so I mean, I guess it's you know, in some ways this is a fairly straightforward paper. It's a retrospective study. I think the authors are, you know, in my view, the authors are appropriately cautious about the conclusions that can be drawn from it. I think they are. My sense of it is that their real interest was in presenting lacosamide as an option, and to show that in general terms, it seems to be potentially helpful, at least as much as options like gabapentin and baclofen, which are much longer established. And I guess in those terms, and in a sort of basic way, I think we probably all agree that they did that without really kind of setting the world on fire. But it's just a useful kind of again, thinking about this type of study, because there's a lot of studies like that out there. And, those of us who run, for example, busy clinical practices, but are not necessarily, those of us who see a lot of patients, which is probably most of us on these calls, but not necessarily in a position to then enroll all of those patients into full-blown clinical trials. One often thinks about, well, you've seen quite a lot of people, you've treated quite a lot of people, to produce these type of retrospective cohort studies, it is actually quite useful. And again, it's, sometimes it kind of creates questions that we'll then want to go on and ask in clinical trials. Nobody's going to want to go and do any more trials of gabapentin, but it's quite an interesting question that arises from this study: is that was that really just coincidence that all the gabapentin patients that got relief got pain freedom, or was that just it probably was just coincidence, but its numbers are small. So I think these sort of studies are they're very important as a kind of lower level, a layer of kind of the medical literature that allows clinical experience to kind of filter through into determining the sort of questions that might be interesting, to do, further proper trials on. And I think one of the nice things about these types of studies is that they are generally investigator driven. This is people saying, well, we've done this and, we're going to present this and we're not going to claim the world for it. But actually, isn't it interesting to see that you can use this drug, or you can do this, or you can do that? And it's often the starting point for then, more detailed questions to be asked. So, for example, in where I work in the UK now, if one's thinking about, for example, the introduction of cannabinoid medicines, we've got quite a lot of people doing, presenting, kind of retrospective patient outcome, measures in people treated with, medicinal cannabis products. What's the purpose of that, apart from just to sort of advertise the clinics that are doing it? Well, the purpose is to kind of say, well, look, actually in the real world, these things sort of work. And actually, these are the areas which it would be worth, devoting time and energy and effort to, to actually doing proper clinical trials. So, the retrospective cohort study, low degree of quality, but potentially very interesting. And I think this is quite an interesting, nice little, study. And again, just gives a sense that lacosamide might be an option for people to think about. And, and all of us, I'm sure, we've treated trigeminal neuralgia. It's always useful to have other options in your pocket, because, so many of these drugs that we give people, so many people don't really get on with them particularly well. Any other questions, or would anybody else like to make any other comments on either the paper itself or on Dr. Vikram's presentation?
Sir, there is a question from chat box from Dr. Niti. She's asking whether these second-line treatments are useful in secondary trigeminal neuralgias, or we should address the etiology first.
Well, obviously the numbers in this trial were for secondary etiology was tiny. That was a question I scribbled down. Actually, is it more difficult to treat MS-related trigeminal neuralgia than sort of, if you like, idiopathic trigeminal neuralgia? I don't know. My sense is it often is, but then the underlying etiology is often, obviously you can treat, if you have somebody with MS, you're going to treat their MS, but that doesn't always, how are you going to treat MS-related trigeminal neuralgia? It doesn't usually respond to, to immune modulating therapy or steroids. So I guess my sense is that they can be a bit more difficult to treat. I don't know what other people think. The question is what the underlying etiology is. If it's if there's a structural, if there's a structural tumor in the in the IAMs that's causing compression of the trigeminal nerve, and it's firing off and causing pain, then yes, obviously, probably addressing the underlying cause. But I guess the commonest secondary cause that we would normally think about in this scenario
MS.
would be MS, and I think it's quite difficult to treat MS-related trigeminal neuralgia any other way than treating it as one would treat, the idiopathic cause or the form caused by neurovascular contact. Cool. Brilliant. Well, look, Dr. Vikram, well done. You did a very good presentation. Thank you very much indeed. And
Thank you, sir.
it's good to see people here. Obviously, the recording will be uploaded onto the website. We will continue to try and do these meetings, if not absolutely every month, then most months. I think I'm going to suggest that we may leave it for January, but may resume in February, in which case the likely date will be Monday, the 2nd of February. I would obviously encourage all the people working towards the fellowship of the WHS to make sure that they are presenting. It's a good discipline to take papers and actually just try and really think about what you're reading and why people have presented papers in the way that they have. And it's obviously, it's interesting for everybody else just in terms of what the paper says, but also how people put these things together. And obviously the purpose of all of this is to help you guys think about the quality of what you're reading and the limitations of what you're reading, and therefore, what you can believe, if you like, but also what you can bring into your own clinical practice. So as I say, I think the next date will be Monday, the 2nd of February. Volunteers very much appreciated for the next presentation. And otherwise, I wish you all best wishes for the various festive seasons coming up in the near future. So thank you very much indeed again, Dr. Vikram, and all the best to you.
Thank you, sir. Thank you.
Bye.
Cheers.
Thank you so much, sir. Thank you everyone for the kind.
Thank you, sir.